All right, let's get going for today. So, good morning, welcome back. Little bit of reminders. First of all, you should have gotten the lab exercises for the nervous system completed for Tuesday, and then for today, you had the nervous system assignment under course content. So, you should have gotten 2 assignments done up to this point. If you haven't, uh, you're missing these due dates that I've been reminding the class about at the start and end of each lecture. And it's very important that you make sure that you're getting this work done. These are a significant part of your grade. Late assignments are going to have points deducted from them, so please make sure that you're paying attention to these announcements. And if you missed that work, I'm going to need to reactivate it for you if you're intending to make it up, which you should, so please reach out to me. So I know that you're aware that you've been missing work. So please double check that you've gotten both of those nervous system assignments done. In addition, we have the first lecture exam coming up, the start of not this coming week, but the following week, which puts us at about 11 days, 10 or 11 days away from the exam number 1. If you haven't been studying aggressively at this point, you really need to start doing that now, because you'll see that today we have a very full lecture, and today's lecture is, and a little bit after today's lecture, it is going to be found on the first exam as well. So you have that whole nervous system, sensory system, peripheral nerve handout, and then what we're covering today and a little bit next week on that first exam. So it is a lot of material. You really want to make sure that you are taking your time with it. So any questions about anything before we shift gears, jump right into learning our next topic on the cardiovascular system? Okay. All right. So, so what we have to describe today, we're going to get started looking at this cardiovascular system. Cardio refers to the heart and vascular to blood vessels. So it's the system of the heart and the blood vessels that are responsible for transporting blood in the body. The heart being the structure that will pump the blood, push it through the vessels, and the vessels being the tubule system that will transport the blood through the body. Ultimately, the cardiovascular system can be divided up into 2 circuits, which we'll see on the next slide here. The pulmonary circuit, pulmonary referring to lungs, and then systemic circuit referring to the rest of the body. So we'll have the blood flow to and from the lungs, and then the blood flow to and from the body. So our pulmonary circuit we see here is going to be powered by the right side of the heart. The right side of the heart we see there. So the pulmonary circuit, the right side of the heart is going to pump its blood to the lungs, and then the lungs will return that blood back to the left side of the heart, and that completes our circuit. So our circuit, basically a loop, the right side of the heart powering this loop, pumping blood into the lungs and having that blood return back to the heart. The reason for pumping to the lungs is because the blood that is being pumped is deoxygenated, low in oxygen. It means that it needs to be pumped to the lungs to pick up oxygen that it can then carry back to the left side of the heart to be transported through the body. So our right side of the heart pumping deoxygenated blood to the lungs, and the pulmonary circuit, the blood going to and back from the lungs. And then we have the systemic circuit, which will be powered by the left side of the heart, and this will be pumping our oxygenated blood. So oxygenated blood shown in red here, that the left side of the heart will pump blood containing oxygen to the upper body and lower body, basically to the entire body, the systemic body of the entire system. So our systemic circuit, the left side of the heart pumping blood to the body, and that blood returning back eventually to the right side of the heart to begin this whole process again. Okay, so we have these two circuits, and we'll dive into those more as we go on. But before that, we're going to see a little bit more on the general anatomy of the heart. First of all, its position in the chest. We see that it's positioned deep to the sternum and slightly offset to the left of the chest. We saw the cardiac impression in the left lung back in A&P1. So that indentation in the left lung as the heart takes up a little bit of space on the left side. We also see a couple of terms about the heart where the base is actually at the superior portion. The base is the wider portion with the blood vessels, and the apex is the pointed tip at the inferior portion. So that may seem kind of upside down when you think of base and apex. You know, usually you think of the base as the thing that's on the bottom and the apex at the top. But basically what we're saying here is the base is the wider portion and the apex the pointier, narrower portion. And this slide is here to show you that the heart, just like the lungs, is going to be wrapped in a couple of connective tissue layers that trap a fluid that's protective of the heart. And so where the lungs were wrapped in the pleura with the pleural fluid, this will be the pericardium. So similar to the pleura where we had the visceral portion and the outer portion there, and it created a cavity in between. We have the pericardium doing the same thing, basically wrapping up, protecting, and isolating the heart. So the heart is not just sitting there exposed to the rest of the inside of the chest wall, but instead it's basically wrapped up in a protective connective coat. So what we have to do with the next several slides is explain the process through which the blood will circulate into and out of the heart. And we start off by looking at the blood vessels that are going to be involved in both the right and left sides of the heart. And to do this, we want to introduce a general point here, and that is that arteries carry blood away from the heart, whereas veins will carry blood to the heart. So arteries carry blood away from the heart. Put your A's together. Arteries will carry blood away from the heart, whereas veins will be the vessels that bring blood to the heart. So keeping that in mind, this is going to help us in naming the blood vessels on the following slides here. So our arteries and veins, we got to name them based upon their activity. So our blood vessels we see from the right side, we have the superior and inferior vena cava, so these will be veins that supply the right side of the heart with blood. So when we look at this structure here, the right side of the heart, the blood comes into it through the superior and inferior vena cava. Superior and inferior vena cava. Superior vena cava carrying blood from the upper body, and the inferior vena cava carrying blood from the inferior lower part of the body, and bringing all that blood to the right side of the heart. And then the right side of the heart will pump its blood to the lungs, that we already said. And so it's going to pump away from the heart to the lungs. So if it's pumping away from the heart, it's an artery. And if it's going to the lungs, the pulmonary artery is what we see coming out of the right side of the heart. Right side of the heart, pumping its blood to the lungs through the pulmonary artery. So we said the right side of the heart was going to pump blood to the lungs. What we added to this is that it gets that blood from the superior and inferior vena cava, and it sends the blood to the lungs through the pulmonary artery. And then we're going to do the same thing with the left side of the heart. We're going to see where the blood comes in from and where it leaves through. So The blood is coming back from the lungs to go to the left side of the heart. So it is going to the heart. So it's a vein that will be carrying the blood coming from the lungs, a pulmonary vein. And we see its contractions will send the blood then through the largest artery, the aorta. So going back to this, our blood returns from the lungs through the pulmonary veins. And the pulmonary veins supply the left side of the heart, which will then pump its blood through the aorta. Okay, so still looking at these same two circuits, but now what we've added to it is the veins that bring the blood to each side of the heart and the arteries that carry the blood out of each side of the heart. Next thing we have to add to this whole system is the chambers of the heart. So now instead of just saying right side heart, left side heart, we're going to split it up into the right and left upper portions, which are the atria. The atria are the superior parts of each side of the heart. And then the ventricles, the inferior parts of each side of the heart. So going back to this image here, it's not just blood going into the right side heart. There is a superior part that is the atrium, and an inferior part that is the ventricle, superior part that is the atrium, inferior part that is the ventricle. And what these images show you is that the atrium is very thin walled. The reason why it has a thin wall is that the atrium's job is just to take this blood and push it down into the ventricle. So it doesn't need to work very hard to do that. Whereas the ventricle has to push the blood to other regions of the body. So the right side of the heart has to pump blood to the lung. So it needs a thicker muscular wall around the ventricle. And the left ventricle has to pump blood to the whole body, so it needs to have a very thick muscular wall to pump that blood through the whole body. So those are our four chambers. We have the right side atrium, the right side ventricle, left side atrium, the left side ventricle, the atria being the thin-walled point at which the blood comes into the heart, and the ventricle being the thicker walled portion that is going to push the blood out of the heart. Okay, so we now have seen the four chambers of the heart. We've seen the blood supply into and out of the heart. What we have left to describe are the valves that will be responsible for controlling the blood flow so that it only goes in one direction. So if you imagine this ventricle here, when this contracts and squeezes the blood, we want that blood to go into the pulmonary artery. We want to make sure that it goes in this direction here. We want to make sure that it doesn't accidentally go back into the atrium. We don't want it to be squeezed backwards, or else that's not going to be efficient at transporting blood. We want that blood to be pumped only in one direction, and so we're going to have valves that control the flow of blood so they can only go in one direction. Our first set of valves are the AV or atrioventricular valves. Atrioventricular meaning that they are found between the atria and the ventricles. So these are going to control the blood flow between the atria and ventricles. And we can relate these to our topics in A&P1. In A&P1, I told you you're going to want to remember the number of lobes of the lungs, and it's going to help you out with the heart. So now we're at that time where I can remind you or ask you, how many lobes did the left lung have? How many lobes did the left lung have? 3, right? The left lung had 3 lobes, and how many lobes did the right lung have? 2, right? So this was something I said back then. I was like, guys, remember, right 3, left 2. This is going to help you later. Well, this is later. And this is where we see, when we look at heart valves, they're going to have that same pattern. The right side of the heart, the right atrioventricular valve, is called the tricuspid valve. The reason why it's called the tricuspid valve is it has 3 cusps, and a cusp is basically a flap. So it's got 3 cusps that make up its structure. Whereas the left side of the heart, the left AV valve, has only 2 cusps, so we call it the bicuspid valve. So right there, just the same way as the lobes of the lungs, where we had 3 lobes on the right and 2 on the left. Right now we have 3 cusps on the right and 2 on the left when it comes to these AV valves. What complicates this a little bit is that we call the right AV valve the tricuspid valve, and unfortunately we don't call the left side the bicuspid valve as much as we call it the mitral valve. So you'll see images like this one that will actually call it both, but you'll note that they call it mitral valve and then in parentheses bicuspid as the more common term. When we see other images like this one, this is pointed out as the mitral valve. So the mitral valve and bicuspid, 2 ways of saying the same thing. So what these are, these AV valves, these are, with our tricuspid and mitral valves, prevent blood from going back into the atrium. So you want to think of them like one-way swinging doors. So a one-way swinging door. When the atrium contracts, the blood swings the door open to push the blood into the ventricle. But when the ventricle contracts, as it pushes on that same door, that causes that one-way swinging door to swing shut. So the contraction of the ventricle causes the AV valves to slap shut. And that means that blood cannot go back into the atrium. It's forced to go into the arteries, which we want it to do because we want it to go only in one direction. So our AV valves, the tricuspid and mitral valves, make sure that the blood doesn't go back up into an atrium going backwards. And then we have to make sure that our blood that goes into the arteries doesn't accidentally work its way back into the heart. So we have these semilunar valves that are found in the 2 major arteries that are responsible for making sure that the blood stays in the arteries and doesn't go backwards into the heart. So the semilunar, basically half-moon valves, are found in the 2 arteries, the pulmonary and the aortic arteries. So going back to this image here, we see the example of the pulmonary semilunar valve, that as blood is pushed into the pulmonary artery, the ventricle is then going to relax. It's going to expand and open up. As it opens up, that would create a suction that would pull the blood back into it. That would be a major problem if you pumped blood out and then it sucked the blood right back in. So we have these semilunar valves, these half-moon shaped valves that prevent the blood from going back into the ventricle and make sure that the blood stays in the arteries. These 2 sets of valves are what create your heart sounds. So when your heart is beating and it goes lub-dub, 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 that beating sound is not the movement of the muscle. It's not, you're not hearing like lumping, bumping sounds coming out of the heart. What you're hearing is the doors slamming shut. You're hearing these valves slapping shut. So the lub, the first heart sound, is the slamming of the AV valves, and the dub is the slamming of the semilunar valves. So you're hearing these slap shut, lub, then these slap shut, dub, and that is the actual heart sound that we listen for. And on a related note to listening to heart sounds, when these valves malfunction, and they let blood leak through them, that is a heart murmur. So heart murmur is any leakage through these valves. And that is heard as basically a swishing sound when you're listening to the heart. So if we take, for example, a leaking AV valve, blood flows through it, it slams shut. We hear lub as that slams shut. But then as the ventricle contracts, it lets a little blood squirt back through it. As the blood squirts back through it, we hear a swishing sound. And then we hear these valves shut. That's the dub. So it goes lub, swish, dub, lub, swish, dub, lub, swish, dub, as those AV valves malfunction. Whereas if the semilunar valves were to malfunction, then the lub goes just fine. There's no backwards movement. There's the dub as this slams shut, and then the swish comes after that slam shut as it lets blood come back through it. So lub, dub, swish, lub, dub, swish, lub, dub, swish would be a leakage of the semilunar valve. Okay. So any questions about anything that we've described so far between the blood vessels, the chambers, the valves, anything so far? All right. So we pull it all together for the next two slides. This slide here and this slide here summarize everything that we just went through with the exception of a couple of terms in the beginning. But for the most part, this brings almost everything together from all of those previous slides. So if you understand these two slides, then you understand everything we just did. And we're going to go through this twice. So the first time we go through it, is right now. We're going to say, okay, so what is going on with the flow of blood in the heart? Well, the superior and inferior vena cava bring blood into the right atrium. Superior and inferior vena cava bring blood into the right atrium. The blood in the right atrium is going to go through the tricuspid valve to go into the right ventricle. So it's going to go through the tricuspid valve to go to the right ventricle. As the right ventricle contracts, it will push blood through the pulmonary semilunar valve to go into our pulmonary artery. So the pulmonary semilunar valve goes to the pulmonary artery. The blood is now supplied to the lungs. The lungs add oxygen to that blood and send the blood back through the pulmonary veins to the left atrium. So we have the lungs sending the blood back through the pulmonary veins to the left atrium. The left atrium will send the blood through the mitral valve to the left ventricle. So left atrium through the mitral valve to the left ventricle. The left ventricle will contract and send the blood through the aortic semilunar valve to the aorta. So the left ventricle through the aortic semilunar valve through the aorta. That is what supplies our body with blood. So our blood travels through its arteries, arterioles, capillaries, venules, veins, all the way through the system before returning back to the heart through that superior and inferior vena cava. So that brings us right back to where we began with this process. One more time without jumping back and forth. Following blood flow through the heart, through the whole body. How does this work? Well, the heart is supplied first on the right side by the superior and inferior vena cava, bringing in blood to the right atrium that sends its blood through the tricuspid valve to the right ventricle. The right ventricle sends its blood through the pulmonary semilunar valve into the pulmonary artery. The pulmonary artery sends the blood into the lungs. It sends the blood back through the pulmonary veins back to the left atrium. The left atrium sends the blood through the mitral valve to the left ventricle. The left ventricle sends the blood through the aortic semilunar valves to the aorta, which supplies the body with the blood. That blood comes back to the right side of the heart through that superior and inferior vena cava. So that is everything that we've discussed at this point, but putting it all together in one continuous circuit here. Does anyone have any questions about understanding that circuit, understanding the direction of the flow of blood? All right. So you're going to want to be able to pick up with this wherever. So instead of trying to memorize it like it's only this order, realize that if I said, you know, blood is in the left ventricle, where does it go next? Well, blood in the left ventricle, realize that where it's going to go next, it's going to be pumped through to the aorta. So in order to get to the aorta, it's going to go through the aortic semilunar valve. You know, blood is in the right atrium. Where does that go next? Well, blood in the right atrium is going to go to the right ventricle. In order to get there, it's going to go through the tricuspid valve. So work your way through this and understand it as a sequence, but be able to imagine, you know, starting from anywhere, okay? Now, the interesting thing about this is as the heart's pumping all this blood, it's actually getting nothing out of this blood as far as being able to sustain itself. The blood that it's pumping is not giving the heart nutrients. It's not giving the heart oxygen. The heart is just pushing this blood through it. It still needs blood vessels to supply it with the oxygenated blood that it needs for its own survival. So the very first branch coming out of the aorta is the coronary artery. So we see here the heart has just pumped, that left ventricle has just pumped the blood out of the heart, and the first thing that we see coming out of the aorta are branches coming right back to the walls of the heart. So we need blood for the walls of the heart. That blood inside the chambers was not helping us. We need blood in the muscular walls. So these coronary arteries are branches that are going to bring oxygenated, nutrient-rich blood into the heart walls and keep the heart muscle alive. The coronary artery is particularly important when you consider what happens when it is blocked. If you get any blockage, what happens there is if you block blood flow through it, then that means that this wall right here is not getting the blood it needs to survive, and that part of the wall is going to starve and die, and that is a heart attack. So myocardial infarction is when the coronary artery gets blocked and blood flow is cut off to the heart wall. And heart attacks vary in their severity. So you'll hear about people who have had heart attacks that they didn't even know they had a heart attack. And the reason why is because you're dealing with a small vessel that's being blocked. So let's say you get a small blockage right here. So this area of heart dies right here. Well, the whole rest of the heart's working, so the person doesn't even get symptoms from that. Whereas if the blockage occurs earlier in the artery, so if you cut off the artery right here, then you've now cut off blood flow to half of the heart. That person is the one who suffers the massive heart attack that kills them. The other thing that relates to the coronary artery is the remedy for these blockages, which would be a bypass surgery. A bypass surgery is when they identify a blockage and they take a blood vessel from your leg and attach that blood vessel so it runs from before the blockage to after the blockage as an alternate route for blood to flow. And so by giving an alternate route, that means that if you get your blockage that finally gets fully occluded, like a traffic jam on the highway, well, you have an alternate route around that traffic jam. So your bypass surgeries are a way of preventing those blockages from being deadly if they occur. And so if somebody is described as having, like, let's say a double bypass or quadruple bypass, that tells you how many of those bypasses had to be done. So if they say somebody had a triple bypass surgery, that means they put in 3 areas that they added in an alternate route. So any questions about the coronary arteries or how they relate to supplying the heart with the oxygen and nutrients that it needs, and how that's relevant in cases like a myocardial infarction? Okay. So our next point about the heart will be conduction of electrical impulses through it. So the electrical impulse is going to be needed to stimulate the heart to contract. And so we'll be looking at how we transmit that electrical impulse through the heart so that the heart can contract in a coordinated manner to create the heartbeat that we need. And the first thing we see here is that the pacemaker of the heart is the SA node, the sinoatrial node. So this is in the upper right atrium. So the SA node in the upper right atrium is what starts the contraction of the heart by sending the signal to tell the heart that it needs to contract. So it is the pacemaker because it is what sets the pace. It's what tells the heart to contract. The interesting thing about the SA node is that it actually operates without nervous system stimulation. It can depolarize and send a message to contract on its own. So the heart can actually be removed from the body, be placed in an electrolyte-rich water solution, and it will continue to beat on its own, having been removed from the body, because it doesn't need the nervous system to tell it to contract. The SA node depolarizes and sends these messages to contract on its own. We'll see that the SA node can be adjusted by the nervous system, but it actually sets the resting heart rate on its own. So now, that SA node sends the signal for the heart to contract. That signal will travel through the atria, causing the atria to contract, and it will reach the atrioventricular node that is, we see here, the gateway to the ventricles. So what's important here is that this signal told the atria to contract, but it does not go right to the ventricles. The signal cannot go right into the ventricles. Instead, it has to go through this AV node. This AV node is the gateway to go into the ventricles. What this does is it puts in a delay that is necessary for the heart to be coordinated. If this impulse could go right from here all the way down into the ventricles in one burst, then the atria would be contracting at the same time as the ventricle, and so the atria would be trying to fill the ventricle while the ventricle is generating pressure and shutting that AV valve. So the two would be working against each other if they were contracting at the same time. But since the atria is allowed to contract first, it's going to fill the ventricles before that message goes to the ventricles telling the ventricles to contract. So the AV node is a built-in delay that makes sure that the ventricles don't contract at the same time as the atria. So the atria contract, that message goes to the AV node. The AV node depolarizes, sends the message now to the ventricles, and it sends it to the ventricles through the AV bundles and these branches called the Purkinje fibers. So we have branching of the AV bundles to the right and left side of the heart, and the Purkinje fibers that spread out throughout the heart wall. So our AV bundles and Purkinje fibers spread out, and they make sure that then all of the ventricular muscle contracts at the same time, producing a powerful, coordinated ventricular contraction. Okay, so we have this rapid message being sent all through the ventricle and giving one big, powerful contraction. Whereas the atria, it's going to spread more through what we saw before with the gap junctions. This is going to spread it out in a way that the atria are going to contract, but without the same amount of strength as the ventricles. They don't need that much strength because they're just pumping blood down. So the atria don't really have to work that hard to get their job done. So any questions about the role of the conductive system here, sending messages through the heart to coordinate muscle contraction? All right. Well, this electrical impulse is something that we can measure. So using an electrocardiogram or ECG, we see here that it's the same thing as an EKG. So yes, kind of confusing that electrocardiogram is spelled with a C, but then in common life, we're going to refer to it as an EKG. It is the same thing. So if somebody says ECG or EKG, they're talking about the same electrocardiogram. And ultimately, the electrocardiogram allows for us to see these electrical impulses as they travel through the heart. The way this works is that we will use electrodes that are placed on the skin. And these electrodes will receive that electrical stimulation as it is generated, and they'll be able to take that electrical stimulation and graph it out, creating this electrocardiogram. So the EKG shows you the electrical conductivity going on in the heart. And I'll just start off by saying that EKG is something that you could take an entire class in. EKG is very complicated. You can generate all different kinds of printouts, all different kinds of graphs using EKG. The placement of the electrodes can vary greatly. There's all sorts of different ways to generate EKGs and interpret EKGs. And so we are not dabbling in that at all. This is not an EKG class. You do not need to stress out about it. As far as feeling like you're prepared after today's class to go and perform an EKG. But what you want to get out of it is that this is what's considered a really like basic, prototypical EKG graph. This is what we call the lead 2 EKG, which we see here waveforms that we can interpret as meaning the following actions within the heart. So our first waveform, the first thing that we see is this P wave. And the P wave is the electrical impulse that's associated with the atria contracting as it depolarizes. So no surprise here, the first activity out of the heart is the atria contracting, the atria depolarizing. And that is our P wave. Then there's a segment before the next bump. These segments represent relaxation. So the atria just contracted. Now it has a moment to relax. Before the QRS complex. The QRS complex is the next big waveform. And that big waveform correlates with the ventricles contracting. So the depolarization of ventricles. So our atria contract and relax, our ventricles contract and relax. And what we get at the end is this T wave. The T wave you see here is the ventricles repolarizing. So the ventricles repolarizing, so basically resetting, so they're prepared to depolarize again with the next heartbeat. So if you're following along with this, you may be feeling a little weird about it, where you're like, well, wait a minute. So the atria depolarize, the ventricles depolarize, but then the ventricles repolarize, but we didn't say anything about the atria repolarizing. The reason for that is the atrial repolarization is occurring and being lost in this QRS complex. So you're not seeing the atrial repolarization the way that you see the ventricle repolarize. What you want to get out of that P wave, atrial depolarization, QRS, ventricular depolarization, T, ventricular repolarization. And we will do a lab on this. And the lab will make you play with this a little bit more and really work with this wave more. So you'll get to play around with it a bit. But for now, that's all you're responsible for is what we have written here. So any questions about the meanings of the P, QRS, and T complexes that we see through there, those different waveforms? All right. So we'll throw out our first of the heart jokes right here. So we'll shout out to Hadaway. Not sure how relevant the song is anymore for people, but that was like the song for roller skating parties back in the 90s. So now you know. All right. So cardiac output is our next topic here. Cardiac output is the volume of blood that the heart is going to be able to transport through it in a minute. So we use the unit of time of 1 minute for the cardiac output. And we see here the cardiac output then is a measure that has two factors to consider. The first factor, the stroke volume. Stroke volume, how much blood in milliliters is going to be pushed through the heart with each beat. And then the heart rate is the number of beats that occur each minute. So we can take these two and multiply them together, and beat on the bottom, beat on the top, those cross out, and what we get is cardiac output. What is left? Milliliters over minutes. The volume of blood pumped out in a minute. That's exactly right, Ashley. I'm glad that somebody made a reference to Roxbury. Yep. So for anybody that didn't get this joke, then you probably aren't getting the Night at the Roxbury reference either. And for that, I am sorry. All right. So how much blood the heart beats in a minute is how much blood it pushes out with each beat times the number of beats in a minute. Let's dive deeper in these two factors here. Let's start with stroke volume. If somebody is an endurance-trained athlete, what is going to happen to their stroke volume? The amount of blood they pump with each beat. What's going to happen to the endurance-trained athlete's stroke volume? If you're an endurance-trained athlete, what's that going to do to the amount of blood that your heart pushes out with each beat? It's going to increase, right? Substantial increase right there. So if they are pushing out more blood with each beat because their heart is stronger, pushing out more blood, what does that mean about the heart rate then if the person is at rest, needing the same cardiac output as an average person? What does that mean about their resting heart rate if their stroke volume is now bigger? What does that do to their resting heart rate? Remember, they need the same amount of blood as an average person, but each time it beats, it's beating more. So what does that mean about the number of beats per minute that they need? It's going to decrease, right? The concept here, your endurance-trained athlete at rest is going to have a much lower heart rate than a normal person, an average person, because each time their heart beats, they push more blood out, so they don't need to beat as often to get the same cardiac output as an average person. So the resting heart rate of the endurance-trained athlete is lower to end up with the same amount of cardiac output as anybody else. Now let's compare that to the person who has had a heart attack. Somebody has a heart attack that damages the heart wall. The damaged heart wall means that the heart can't beat as strong. The heart cannot beat as strong, then the stroke volume is going to go down. They can't push out as much blood with each beat. What does that do to their heart rate if their stroke volume has gone down? What does their heart rate have to do to give them the same cardiac output? Have to increase, right? Is that good for somebody who's had a heart attack to have a resting heart rate that is faster than normal? Yeah, right? No, the heart has to work harder, right? Do you see how this is a very slippery slope? That something like heart disease is very problematic because it's a downward spiral where we have a situation that the person who suffers the heart attack, their heart has to work harder now because it's not doing as good of a job, so it has to work harder. How crazy is that? So there's no recovering from a heart attack where it's like, oh, okay, we'll give your heart a little break here. No, if your heart is not in good shape, it's got to work harder to compensate for the fact that it's not in good shape, which means that it's at even greater risk of, further complications. So don't have a heart attack. So what we see here, we put our numbers together. We see stroke volumes about 70 to 80 beats per, or milliliters per beat, and that we have a resting heart rate of around 70 beats per minute in the average adult. So we work that out to be about 5.5 liters being pumped per minute, with the fun fact being that 5.5 liters is the actual total volume of blood in the human body. So in other words, the heart is capable at rest of transporting an equivalent amount of blood through it in 1 minute as there is blood in the entire body. Now, how we go about measuring that heart rate is taking a pulse. The pulse is the expansion of an artery as blood is pumped into it. So it's like inflating a balloon. As blood goes into the artery blows up a little bit. And that's something that we can actually feel as we feel the expansion of the artery, that is the pulse. We see here that the pulse or the heart rate in infants is very high, so over 120, whereas the average adult somewhere in the 70 to 80 beats per minute range, with women averaging more than men at a resting heart rate. And the center of the brain that's responsible for monitoring your heart rate, making sure that the necessary adjustments are made to it, is the medulla. Medulla we saw was the lower portion of the brain that was responsible for regulating heart rate, blood pressure, respiratory rate. So it was all those vital functions. And ultimately, it's going to regulate the heart rate through the pathways that we described in the first lecture, those nervous system pathways that were the sympathetic and parasympathetic pathways. The sympathetic, we said, sped up the heart rate, and the parasympathetic slowed it down. So here's how that works, because this may sound confusing at first. At first I said, hey guys, you have this SA node that controlled your heart rate. I said the SA node was the pacemaker, and that your heart could beat without even being attached to the nervous system, because the SA node set your heart rate. That's true for your resting heart rate. At rest, your SA node naturally depolarizes at the resting heart rate, giving you that resting number of beats per minute. So let's say your heart rate is 60 beats per minute. That means the SA node depolarizes once every second, generating 60 beats per minute. But that resting heart rate is not always appropriate. Sometimes we need to adjust it, and the way that we adjust it is by sympathetic and parasympathetic stimulation of that SA node. So the nervous system can step in and say, okay, you've seen a bear. Now that you've seen a bear, let's stimulate the SA node to depolarize faster. So instead of the slow depolarization, let's stimulate to depolarize faster so it beats more often. So we get faster heart rate through sympathetic nervous stimulation. Whereas the parasympathetic nervous system stimulation is going to inhibit this depolarization we see here. So it's going to draw it out, make it longer to depolarize, so we get fewer beats per minute. So the parasympathetic nervous system slows the heart rate down during your rest to digest, where the sympathetic sped it up. But all this goes back to, once again, that SA node sets the pace, and then the nervous system can adjust it. So we have a couple of conditions to consider where the heart rate is different from what we would expect at rest. That is underlined in both of these, that we are talking about a resting heart rate that is being changed. It is normal for your heart rate to change if, let's say, you are active. If you start running, your heart better beat faster. That's you adjusting to a new level of activity. But in this case, we are saying with tachycardia, this is an increased heart rate, more than 100 beats per minute, when the person is at rest. So they shouldn't have a need for the heart to beat 100 times per minute. So what causes this? We see here stress and anxiety. So we talked about stress and anxiety stimulate the sympathetic nervous system, and that increased our heart rate. So you're sitting around worrying about, upcoming test or crisis that's going on in your life, and heart rate increases. We see recreational drugs. Some of them are stimulants that will increase the heart rate. We see heart disease, what we talked about back here. So the person who has a heart attack, their stroke volume is less, so their heart rate goes up. So that poor person who had a heart attack now has tachycardia to compensate for the injured heart. And finally, increased body temperature. We actually saw this back in A&P1 when we talked about dehydration. We said dehydration led to hyperthermia. And so hyperthermia was the increased body temperature. And one of those things that comes along with the increased body temperature was increased heart rate. So tachycardia, basically your whole body is kind of in overdrive in compensation for the dehydration. On the flip side of it, we've got bradycardia, which is a resting heart rate less than 60 beats per minute. We see here that this is going to occur during your sleep cycles, but it's also pretty normal for an endurance-trained athlete to be below 60 beats per minute. So when you look at that, you realize bradycardia is really not a problem, right? So this isn't a health condition. This isn't something to be worried about. If your heart is able to do what it needs to do with fewer than 60 beats per minute, then that's good. The only problem that we would be concerned about is if for some reason you should be having more beats and you're not, so that, there's maybe that consideration that the SA node is not doing what it's supposed to do. That wouldn't be a regular rate. That would be an irregular rate below 60. So where someone would go beat, 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 beat. That kind of thing is a sign that you've got an SA node that is not working properly, and that's where you would intervene with a pacemaker to adjust the activity of the SA node because it's not beating regularly enough. But in reality, bradycardia, more often than not, this is a good thing. Less than 60 beats per minute is a sign of generally good health. My last exam in the fall, I think my heart rate was about 42 beats per minute, and so you can see that how extreme that can get. I mean, 42 beats per minute, and instead of the doctor reacting like, oh my God, there's something wrong with you, you should go see a cardiologist because you have bradycardia, it's, like 42 beats per minute. They're like, cool, all right. So no big deal. And it's good to have a good resting heart rate in that range of bradycardia. All right. Any questions about anything so far? All right, so the next thing to consider is blood volume. So blood volume is very low, all things considered. So when we consider the fluid volumes of the body, we see here that our body is made up of by about 40 liters of fluid inside and in between our cells. So your body is about 40 liters of fluid. And then the blood is there to balance out and maintain homeostasis in those 40 liters. So we're trying to clean out and balance out that 40 liters, but we only have about 3 liters of blood plasma. So remember, blood was 5.5 liters, but some of that is the cells that are in the blood. So when it comes to just the plasma itself, you only have about 3 liters of blood plasma to balance out 40 liters of blood in your tissues. I'm sorry, 40 liters of fluid in your tissues. So this is a problem. We do not have a lot of blood to share with the body. And that's what's explained here, is how we're going to have to adjust the directions in order to, well, the direction of blood flow in order to make sure that blood is going where it is needed. So what we're seeing here is at rest. Where is blood needed? Well, blood is needed in the digestive system to absorb nutrients. It's needed in the heart. The kidneys, we said, gets about 20% of blood flow in AMP1, so we can keep that blood filtered. And then the brain, but we see the skeletal muscle only gain about 20% of your blood flow. So the musculoskeletal body, the bone, and the muscle, even though it's most of your body is the musculoskeletal body, it only gets 25% of your blood flow at rest. But then if we start to exercise, we need to divert blood. The musculoskeletal body is what needs the energy right now, so we shuttle over about 80% of the blood to the musculoskeletal body. That means we've got less blood to share everywhere else. We've got to cut off blood flow to the digestive system, to the kidneys. We maintain our blood flow to the heart, to the brain, because you got to keep those things functioning. But for the most part, the point of this slide is to say that when you have a shift in your level of activity, you have to be able to divert blood since we only have a small amount of it. So we can't keep sending 20% of our blood to the kidneys when we're exercising. We don't have enough blood to do that. And that relates then to blood volume. It's very important that we maintain our blood volume, especially since the job of the kidneys was to create urine from our blood plasma. So every ounce of urine that you make is an ounce of blood that you just lost. Remember, urine is made from blood plasma. So in producing urine as a way to clean the blood, we are also losing blood. And that relates back to one of the topics that we had back in AMP1, which was our hormones that were needed to reduce urine production to maintain blood volume, and those were ADH and aldosterone. So I told you guys you'd see them again. This is the first of 3 times that we're going to talk about these 2 hormones again, where ADH and aldosterone worked on the kidneys to increase the amount of water and sodium that we reabsorbed while making urine. And in that way, it prevented us from making too much urine. So we don't want to make too much urine, because if we do, that is going to decrease our blood volume. And if we decrease our blood volume, then what that is going to affect is our blood pressure. So we're about to explain blood pressure, but let's take a minute here. Any questions so far? All right. So blood pressure is the pressure that the blood exerts on the walls of the blood vessel. And we see here it's measured with the sphygmomanometer. That is the technical term for a blood pressure cuff. And what we measure are 2 levels of pressure. The systolic pressure, that is the maximum blood pressure within an artery. This occurs as the heart beats. As the heart beats and it pushes blood into the artery, for that moment, the artery takes on an extra volume of blood, and its pressure goes up. So the highest pressure within the artery is the systolic pressure. And then we have the diastolic pressure. The diastolic pressure is the lowest pressure within the artery. This is the this is the resting pressure within the artery. This is the moment during which the heart refills, and so at that time, there is no additional volume being added to the blood vessel, so the blood vessel has no additional pressure besides the normal resting amount of blood in it, and so its pressure is lower at the diastolic value. So our systolic and diastolic pressures, our highest pressure and our lowest pressure within the artery, we list one on top of the other, systolic over diastolic, and that is how we reflect blood pressure. And in order to measure somebody's blood pressure, we're going to use this slide and this slide to explain this, but I'm going to do it by drawing it out on the whiteboard here. So please follow along with the whiteboard as well as your notes if you're able to. So what we have going on is here's our blood vessel. And our blood vessel has blood pressure in it because the blood is coming in under pressure. So we have the blood pushing against the wall. So what we have here is blood pressure from blood pushing against the wall. We have blood pressure at rest here, that as this is filled with fluid, that fluid is applying pressure on the inside of the wall. Now, blood flow is traveling in a way that we described in AMP1 for the way we described air traveling through a tube. We said that anything traveling through a tube, air or fluid, it travels through in what we call a laminar blood flow or laminar flow. So laminar blood flow, laminar meaning undisturbed. So an undisturbed blood flow where it just undisturbed, it's just flowing right along without any obstacles in its way. And we see that it flows very uniformly. So you want to think of this like water in a stream. So water in a stream where the stream has no obstacles in it. There's no curve to it. There's no rocks in it. It is just water going down a peaceful stream. So if I go and I put a stethoscope on the artery right here, remember, this is undisturbed blood flow. Am I going to hear anything if I put a stethoscope on this artery that has laminar undisturbed blood flow? Am I going to hear anything? Right, so no sound. No sound associated with this. So if I took your arm and I put a stethoscope on your artery to listen to it, I'm not going to hear anything. Okay. But if I come over and I put on a blood pressure cuff, now I'm going to throw in a new factor here. So if I come over and I put on a blood pressure cuff, let's keep this picture the way it is. I'll just modify this picture. If I add a blood pressure cuff, the blood pressure cuff is going to put this pressure on the blood vessel wall, and it's going to push the blood vessel so that the wall pinches shut. So I overinflate this blood pressure cuff so that I take the walls of that artery and I pinch them together. And so what I have drawn here is a cuff inflated past the maximum blood pressure. And what I've done here is I have fully occluded or closed blood vessel. If I do that, if I inflate a cuff and I fully pinch off that blood vessel, and I'm listening here, do I hear anything? If I cut off blood flow through that blood vessel and I'm listening here, do I hear anything? So I want you to think about this. The blood was coming through here, and now nothing's coming out the other side. Once again, no sound, right? So our two scenarios here where we have no sound are the one where the blood vessel is completely open and the blood is flowing through undisturbed. We get no sound. The other scenario where we had no sound is when we inflate the cuff past the maximum pressure, and in this case, we cut off blood flow so extremely that there's nothing coming out the other end. There's no sound, okay? So that's what's explained for you at the beginning of this whole process of taking somebody's blood pressure, is that it's done by listening. There are no sounds that are heard during laminar blood flow, where there is smooth blood flow with no compression. And what we're going to do is, by inflating the cuff, we're going to inflate the cuff to where the artery is fully occluded and there once again is no sound. So we have a scenario here where the person's blood pressure is 120 as their maximum pressure. We've inflated the cuff to 140. So we have completely cut off blood flow because the pressure on the outside is greater than the pressure on the inside, and we completely collapsed that artery and we have no sound. But where we start to change this up is the moment in between a completely closed versus a completely opened artery. So that moment in between is going to be an artery that's partially closed. Actually, let me just clear this. An artery that's partially closed. So as we have an artery here that is still being squeezed by that blood pressure cuff. This artery is still being squeezed by that blood pressure cuff. We'll label this as a partially occluded artery. Cuff is at a pressure less than or equal to the blood pressure. So it's partially occluded. We're squeezing the artery, but the artery is pushing back. And so the artery is partially opened here. What's going to happen here is that our blood flow is going to come in, but it's going to crash into that wall, and it's going to have to change course, and it's going to bounce off of that, and it's going to bounce through here. Same way blood's going to come through here, and it's going to bounce off, and it's going to bounce through here. And so we have this turbulent blood flow through that partially occluded artery. Turbulent blood flow through the partially occluded artery. Are we going to hear any sounds when we throw rocks into the stream? You know, yes. In this case, this is like the stream now has rocks in it. This is, we have put up obstacles. And so now we have turbulent flow, and this is something that we will be able to hear. So we've got our stethoscope here that we're listening with, and we're going to be able to hear this turbulent blood flow. So this is how taking blood pressure is going to work, is that we will be able to hear during these periods of time where the artery is partially closed, you know, squeezed a little bit. So walking through that, The sound that we will hear is what's called a Korkhoff sound. And this sound is basically a bumping sound. So you have your stethoscope right here, and you are listening, and you hear nothing at 140. Then you start to release the air from the cuff, so it drops 140, 130, still silent. 125, still silent. 120, we hit that moment where the pressure outside is equal to the pressure inside, and that artery starts to open up. As the artery starts to open up, blood starts to push through in a turbulent manner, and we hear the first Korkhoff sound, which is a bumping sound. So you hear nothing, 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 bump, 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 bump. That bumping sound is the Korkhoff sound, and the very first moment you hear bump, that is the maximum pressure in the artery, the systolic pressure. That is the maximum pressure in the artery, the systolic pressure, the very first moment that that artery was able to start to open up. So the first time you hear bump, you write that number down. So if it's silent, 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 and then you hear bump at 110, then the maximum pressure is 110. You know, silent, 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 150, that first time you hear bump. Then you write down 150. So whatever that first number is that you hear bump, that is your systolic pressure. Then you will continue to hear bumps as that pressure continues to drop. So 120, bump, 115, bump, 110, bump, 105, bump, 100, bump, 95, bump, 90, bump, 85, bump, 80, bump, 75, silence. That last bump you heard was at 80. The last bump you heard was at 80. The last Korkhoff sound occurs when the cuff pressure is equal to that lowest diastolic pressure. So you write down the number that was on the gauge when you heard the last bump. That's the diastolic pressure. So you write down the first bump and the last bump while you look at the gauge. So as the gauge goes 130, 120, bump, 110, bump, 100, bump, 90, bump, 80, bump, 70, bump, 60, silence. You know, you would say 70 was the diastolic because that was the last time you heard the bump. So wherever that last one is, that's your diastolic pressure. And that is how we come up with a blood pressure. The maximum pressure, the first Korkhoff sound, the minimum pressure, the last Korkhoff sound. So any questions about the concept of taking blood pressure and why we were hearing noises during that range of the systolic to diastolic pressure? And once again, it's silent at the beginning because we've cut blood flow off. It's silent at the end because we're no longer impeding blood flow. It only makes sounds when we're impeding the blood flow. Okay. Any questions at all about measuring that blood pressure? You guys will get some practice with it in the lab. So it is nice that as much as this right now is sort of the theory side of it, you will get to practice it in a simulation. So you will get that idea of you know, what the heart sound, well, what the pulsing sound sounds like, and also just being able to manipulate looking at the gauge while also listening for the sound. It requires a little bit of coordination. So this is something that students sometimes struggle with at first. It's because you're trying to hold your stethoscope, hold the valve to open and close it, while you're also trying to read the gauge and all this stuff. So it can be a little cumbersome until you get used to it. And the other thing that the simulation does well, and something I always like to emphasize when teaching, is the importance of keeping your patient comfortable, being respectful to your patient during this. If this person's maximum blood pressure is 120, is it appropriate for me to inflate the cuff to 160 to start off? If their blood pressure is 120, is it appropriate for me to go up to 160 to start off? No, right? Oh man, I just realized I wasn't sharing my screen this whole time. I'm sorry about that. I was looking at this, and I forgot to switch over to the arm right here. So I'll go back through this right at the end, just as another visual recap here. It's not appropriate to overinflate. So one of the things that we have to factor in to make sure that we are being considerate to the patient is, well, how do we pick that top pressure? There's a couple ways to pick the top pressure. The first way is you feel the radial pulse down at the wrist while you inflate the cuff. And you stop inflating the cuff once you lose the radial pulse. So that tells you that you've cut off blood flow. Another way to do that is to listen while you're inflating and get to a point where where you stop hearing sounds. And when you stop hearing sounds, then you know once again you've gotten to the point where the artery is completely occluded. So if somebody's at 120 as their maximum pressure, that should have you inflating, somewhere in that range of 130 to 140 without overinflating. And the other thing is that you really need to be ready to measure their blood pressure. So one of the problems that I see is that somebody starts to inflate the cuff before they've even put the stethoscope in their ears. That's crazy. What are you doing? Why are you cutting off blood flow to a person's arm and then taking out your stethoscope? What you should do is place the stethoscope, have it in your ears, start to inflate, and be ready to open up that valve and let out the air the moment that it goes quiet. So you're only inflating it enough to cut off blood flow for a matter of a couple of seconds, rather than leaving the arm with no blood for a matter of several seconds. Oh, I'm sorry, I gotta put my stethoscope in. This valve is a little gummy, it's hard to open. Sorry, am I cutting off blood flow to your arm while I'm messing around? You should be courteous with your patient and realize this is something you inflate only when you're ready to start getting this pressure. So one more time, how do we do this whole thing? We inflated until we cut off blood flow completely, and we had silence. We started to deflate until we heard the first bump, the first Korsakoff sound. That is our systolic pressure. We deflated more and more, still listening to each one of the bumps as we have this turbulent blood flow, until finally we reach the point that the blood flow is no longer impeded. We go back to silence and we write down the number where we heard the last bump. All right? So any questions about blood pressure as we wrap up for today? Okay, so for a final note, once again, up to this point, if you were staying on schedule, you should have had your nervous system lab assignment and your nervous system lecture assignments done. For next week, you have the sensory organs assignment due. So 1 week from today, the sensory organs assignment is due. So you should be jumping on that, getting that completed for next week. And finally, our lecture exam is at the start of not next week, but the following week. So we're already less than 2 weeks away from the lecture exam number 1. So you should be studying aggressively at this point, so that next week when we're meeting on Tuesday for lecture, you really, if you're pacing yourself well, you should feel like you're about 60% of the way through the information going into Tuesday's lecture. If you're any less than that, you're saving too much for that last week, and you're going to find you're quite overwhelmed. So I will conclude the lecture right now. You guys have a good rest of the day and a good weekend. Feel free to hang around if you have any other questions or concerns, okay?